So these are my, I don't know where my conflicts, I thought they were in there, but at any rate, bone morphogenic protein use in elective spine surgery, something that's been with us now for a decade. There are pros and cons, and I think all of us recognize the benefits. I think it does offer the highest fusion rate of any biologic, whether it's autograft, allograft, or cell-based products. And it does avoid an autograft harvest. And what I found in my practice, I've been out of training now 20 years, and I had done iliac crest harvest for almost every fusion. And when bone morphogenic protein became available, like a lot of us, I began using it in off-label uses, and I really found it hard to go away from that when some of the adverse publicity and discussion arrived. We do recognize there are some downsides. It is expensive, and there are complications that I think all of us, and certainly I have seen in my practice, occasionally a neuritis, if it feels to me like it might be related to bone morphogenic protein exposure. And there are parts of the root that are very sensitive, the dorsal root ganglion. And I will say, despite that, feel that I've come to be able to kind of contain the BMP in off-label uses such as TLIF, which is where that is most described. Same for heterotopic ossification. I've seen that once or twice. I don't know that I've ever had a symptomatic case of that, but again, with careful application and reasonable dosing and containment, I think these are relatively limited issues, but they're certainly out there. Inflammation of other adjacent tissues is clearly an issue, and I think that's why most of us have gone away from using it in anterior cervical applications. That's really the one anatomic location that I find it not appropriate, and partly that's because of the side effects, but partly that's also because we can typically successfully get fusion without BMP in an anterior cervical location. And retrograde ejaculation is a real issue, and I believe there probably are higher rates, as was indicated by Dr. Karaji in his famous, and maybe we could say notorious, review of the original FDA approval data. So the question that I think is most important for us to nail down is there an increased incidence of cancer? And something changed on mine. Okay, I'm just going to go off of this one. So this is the original article that Gene wrote as part of an entire volume of the Spine Journal. And in it, he concludes that the level 1 and level 2 evidence from original FDA summaries, original published data, and subsequent studies suggest possible study design bias in the original trials, and that the risk of adverse events with BMP2 is 10 to 50 times the original estimates reported in the industry-sponsored peer-reviewed publications. Of course, that sounds ominous, and I think in fairness, we have to say that there's probably some legitimacy to that some of these side effects were either downplayed or whether it was willful or not, were ignored and not reported. And more concerning is this graph that was published in a subsequent article in the Journal of Bone and Joint Surgery, showing that in the FDA trial for Amplify, there was a statistically significant difference in risk of cancer of all types among the patients that received bone morphogenic protein as opposed to those who did not. And that was touched upon in that original volume as well, but really made more explicit in this article. So in summary, they stated that use of 40 milligrams of RhBMP2 in lumbar arthrodesis was associated with an increased risk of new cancers. Further analysis of the cancer risk associated with RhBMP2 therapy is warranted. And I also find it hard to argue with that conclusion. They're reporting real data. They don't know why, but we've got this statistical issue, and the conclusion is we really need to understand this. And of course, the initial response was contained or was reported by this group and another group from OHSU as well, but this was the group at Yale that performed the so-called YODA analysis. And this was of all of the industry-sponsored bone morphogenetic protein trials. And they did conclude that there was a statistically significant risk here that was greater with BMP. Over the longer term, that difference disappeared with respect to statistical significance. And again, this is a relatively small number of cases. And I think they concluded with a relatively fair statement that at 24 months, the cancer risk was increased with BMP2, but event rates were low and cancer was heterogeneous. So not a lot there, but it still is, we've got this result, and what does it mean? So I think in fairness, they did not maybe overstate those concerns. Of course, this created an enormous brouhaha, and NAS was very involved from the beginning because of the original presentation of these results in the NAS Journal of the Spine Journal. This was their release, and I don't know what this phrase means, embargoed for release. I've never heard that, and I don't know if this, I mean, it clearly was released because I've been able to locate it, but I have no idea what the word embargo there means. But at any rate, this was a relatively strongly worded document, about 1.5 pages long, and among the considerations they brought out was that somewhat ominously, a possible association with cancer was found, and they also were relatively disparaging of Medtronic, stating that to their credit, Medtronic underwrote the $2.5 million YODA project. While this desire for critical self-analysis is praiseworthy, the spotlight must not be completely redirected from imperfect and possibly biased original research to the benefits of open access and transparent post-market data reanalysis. So they are not quite opening their arms back to Medtronic here, and I don't think the relationship between NAS and Medtronic has ever been repaired as a result of all of this, all of these issues. So where did that leave us? Among other things, it was discussed in the media, and this is an article that our former fellow Daniel Drazen and Patrick Johnson and others put together, assessing how this is reported within the lay press, and not surprisingly, they found that only a small percentage of the newspaper articles presented potential complications, and despite a lack of clear scientific causal relationship between BMP and cancer, this risk was disproportionately reported. And additionally, they did not cite the usual scientific sources and called upon physicians and medical organizations to try to rectify that gap and provide better information. Let me see. I thought I had one more slide here. Oh, it didn't come out. I had a nice picture of YODA that would have been hilarious. I don't know why it's not projecting, so I apologize for that. It said, we've discovered YODA's last name. It is Alehihu. That's the joke. Yeah, I told you it was hilarious. Yeah, there you go. I told you it was hilarious. So that's where things stood. And there was, I think, a challenge laid down to try to sort this out and really decide, is there in fact a risk? And I think it is important that we do this work. And since those initial studies, a number of further studies by very credible researchers have been performed, and I don't know that I've got all of those, but I'm going to summarize the main ones and certainly the ones that I think are the most important. So this is a study that was done by Rick Deo and Brooke Martin, and also Sohail Mirza, so a group of physicians and surgeons well known for their skepticism of spine surgery in large part, and they use the SEER Medicare database, and their conclusion was that in a large population of elderly U.S. adults undergoing lumbar arthrodesis, BMP was not associated with cancer risk or mortality. And here's a graph from their study showing that the curves are very similar and really almost overlie each other. So there does not seem to be, at least in this cohort, which is much larger group of data, although lower quality data than a prospective randomized trial, no association with cancer. This is a further study using a different database. This is the Market Scan Commercial Claims and Encounters database. And again, this group of authors concludes, in this retrospective cohort with at least 3 years follow-up, administration of BMP during lumbar fusion surgery was not associated with an increased risk of subsequent cancer. Here, yet a further study. Dr. Chapman was one of the authors on this, as well as Bob McGuire, and this data was abstracted from the Washington State Comprehensive Hospital Reporting System. And this was a 2-year follow-up, and at that time they said there was no increase in overall cancer incidence among patients receiving BMP. An important limitation of this and other studies of BMP and cancer that have been conducted to date is the relatively limited duration of follow-up, and they've extended the follow-up now with this. It'll be coming out soon with a longer follow-up of over 4 years, and this result is still holding true. Yet another group, including Paul Anderson, who's well known to many of us, and Wellington Sue. This was again published in JBJS, and they said they were using the Medicare database retrospectively over a 5-year period from 2005 to 2010. Their conclusion, recent clinical use of BMP was not associated with a detectable increase in the risk of cancer within a mean 2.9-year time window. So almost 3 years, perhaps not quite as long as we'd like, but a reasonable follow-up. And this is a graph out of that data and out of their paper, and they actually found for some cancers a statistically significant reduction in risk among the patients with receiving BMP. So this side means an odds risk of less than 1, and they are less susceptible, at least, or came up with less cases of cancer. So however we slice it, there doesn't seem to be an increase. So there's been now essentially not a meta-analysis, but a structured analysis of all of this published data by Paul McCormick and Kevin Cahill, and this has recently been put out. The first conclusion these authors came to was that of the 2 meta-analyses of the IDE studies that resulted from the YODA project, one was able to detect a statistically significant increase in cancer occurrence at 24 months postoperatively, but not at 48 months. The other meta-analysis did not detect a significant increase in cancer occurrence. So again, I think the concern that was originally developed out of the FDA trial data, while appropriate, may have been a bit overstated. They then called out an independent review of one of the Amplify trials, which indicated that BMP was associated with a 6.75 cancer incident ratio compared with the iliac crest, although a second Amplify study was not included in that analysis. So there is some data that led to this concern, and that is, again, a legitimate issue. However, since then, they reported that there are no case reports that have identified the formation of local malignant cancers, such as an osteosarcoma, after use of BMP in the spine or dental applications. And then they summarized a number of the studies I just presented. One large case series using high doses of the standard formulation of BMP did not identify an increased risk of cancer when comparing with the SEER database. I believe that was out of Washington University, and some of the deformity cases that they were using very high doses of BMP for. Using the Medicare data set, there was no association of BMP with cancer incidence, and in secondary analyses, there was a somewhat lower overall cancer risk with BMP uses, and that's the one I just presented by Paul Anderson et al. Again, using the market scan data set, the overall risk of developing cancer in the BMP cohort was not statistically different from that in the non-BMP cohort, but there was an increased association of BMP with benign tumors in a secondary stratified analysis. And yet a further study that I did not present used the Pearl Diver data, and in that study found the overall risk of cancer development was, if anything, slightly lower in the BMP group with a statistically significant difference. So I think we're accumulating a lot of data. This is not it's not level 1 data, but so far as we can tell, with large numbers of patients, multiple investigators using multiple different databases, no one has been able to definitively show that there's really an issue of concern here. So where does that leave us now? I don't know what's going on as of 2019, but as of 2014, there were already 1,000 lawsuits against Medtronic in process. I think it's safe to say that Medtronic still hates NAS and still boycotts that meeting, and I have a sense that that relationship is never going to be repaired, and I think that is kind of a sad effect of all of this. And I would say to a large degree, the surgical community has moved on, and while I went away from BMP use in certain applications initially, I found that I was getting non-unions again, and I had a hard time making myself go back to harvesting iliac crest, and I have returned in my practice to using bone morphogenic protein off-label in almost every fusion, leaving out anterior cervical applications, as I discussed. And I think this is a worthwhile summary of where things stand as of 2019. This is actually a year or two old, but this is an article from Canada that concludes the literature review. This literature review confirms that the use of BMP2 following FDA approved recommendations is safe, and that they're calling out the one-level ALIF surgery with the LT cage as the primary on-label indication. The rate of complications is low, and the adverse events had been identified by the FDA during the pre-marketing clinical trials. So although it wasn't in the papers, the FDA had the data and knew about the adverse events. The clinical efficacy of BMP2 is equal or superior to that of allogenic or autologous bone graft in respect to fusion rate, low back pain, disability, patient satisfaction, and rate of reoperations. For all other off-label use, the safety and effectiveness of BMP2 have not been established, and further randomized controlled trials with high level of evidence are required. And I find that very hard to argue with. So to some extent, the jury is still out, but I think we do have a large amount of data out there that we can refer to in discussions with our patients in making these decisions. So my initial invitation here was to talk about use of Autograft in spinal metastatic disease, and I'm going to do that just briefly in order to fulfill my promise to Rod and Jens and not be quite as selfish as maybe the first two-thirds of the talk. So this is a very brief, just a couple of case examples, and following Dr. Patchell it's humbling, and I don't have nearly the sort of nuanced understanding and of decision making, I think, that he elaborated, but I think there are patients where we want to have as a goal of surgical treatment gaining a solid fusion. And when is that something that we should really be pushing at? I think of 1 year as about the cutoff. So if we do an instrumented fusion and we get a non-union, the rod fracture or hardware failure resulting from that tends to appear right around a year or maybe a bit longer than that, sometimes a little earlier, but by and large, a 1 year life expectancy would dictate that you want a durable and permanent solution if we're going to intervene surgically in patients, even with terminal metastatic illness. I think there are other issues that come in, and certainly the mechanical stability, as Dr. Patchell elaborated on, and I think we'll have further discussion of, is part of the issue as well. But I think the key key element is how long do we anticipate this patient is going to survive. And of course, that is imperfect. We don't know that with certainty, but we do have some ability to make those predictions. So I'll give close with a couple of case examples out of my own practice. This is a gentleman who came in while I was on call and with a relatively urgent neurologic situation. This does not involve spinal cord, but he did have weakness in the lower extremities. He did have some sense of urinary dysfunction, and he was otherwise very healthy and hadn't known about his tumor, which turned out to be a small cell lung carcinoma. But this is a gentleman who otherwise was healthy, was working and living at home independently with his family, and suddenly is unable to do even routine household activities. He did not have widely metastatic disease elsewhere, but he did have, again, the lung deposit and several other smaller spinal deposits. So this gentleman, I think it's unlikely that he's going to last a lot more than a year, and so we did his construct without bone graft using a spacer of cement put in from the back. As I look at this now, I'm thinking I should have put maybe another pair of rods in there. I don't know, but hopefully this lasts longer or as long as he does. And he's I haven't had him back in clinic. I treated him relatively recently, about 2 months ago, and he left the hospital in much better condition than he came in within about a week of this treatment. Here's another example of a gentleman with uroendothelial carcinoma, a young man with, again, a newly diagnosed lesion and relatively limited metastatic deposits, and he did not have neurologic deficit. You can see he's got a involvement of the C1 lateral mass here on the left. You can see that it's actually slipped out from the articulation with C2 there, and there is the fracture visualized here on the CT scan as well. And he didn't really have a cock-robin appearance, but it looks like he's headed in that direction. And as I was interviewing him, he was in an enormous amount of pain and holding his head with his hands as he's relaying his history, and that had been going on for about 6 weeks. It really took a while for this to get diagnosed. And this is his MRI showing pretty large involvement of the lateral mass and a large mass external to that, but no cord compression really present. And we treated him with occipital to C4 fusion with a resection of the lateral mass. And I did harvest iliac crest here, trying to get a stable and solid fusion that would be durable for him for as many years as he remains. And this is just a CAT scan showing the location of the bone graft posteriorly and the use of the Harms cage there extending from C2 to occipital condyle. And this is a coronal view. There wasn't a cut that had the cage on one image, but shows you the docking of the cage at both ends. So with that, I'll conclude.
Do you see any role of using BMP in a primary bone tumor with lumbar resection? You actually do have a role for cure, obviously expecting life expectancy more than 1 year.
Yeah, I would not. Yeah, I mean, if you're going in that situation where you're hoping for, an indefinite survival, I think in that case you've got to use a combination of allograft and autograft, and I would not use BMP in any cancer application. I don't know. I'm interested to know how the rest of the audience feels. Dan, do you feel differently about that?
Yeah, I didn't hear Pete's question, but one question. He said this, I apologize for repeating it, but say you do a chordoma, sacral chordoma, and it's 4 years out, and there's no tumor, and the rod's break. Use BMP then. So, obviously it's a tumor, obviously it's a primary tumor, probably worse than a met, right, to use that. But it's maybe 4 years out, there's no recurrence, maybe the person's cured, and this person might have really had a hard time with healing, especially if they've had any adjuvants and radiation in the area. So I just wanted to know, I'm actually asking because that is becoming much more of a desire for me to try on these patients that are years out and they fail the construct. And we can talk about vascularized bone, but in the setting of patients who had maybe radiation very challenging. So I just want to know if anyone has.
Yeah, I think that's a great question.
Yeah, I've not. Just redo the surgery. I don't think there's any data for it, but it makes sense to me that that's the case to use it. That's the kind of case where you would love to use it. And a lot of these big sacrectomies, a lot of these bigger sections, I never really convinced myself that I get a great fusion in a lot of these cases, unless I use vascularized bone graft. Then it works very well. But if for some reason you were not able to put a vascular bone graft, then you end up with the situation that you say right now. That's why I'm saying, when would be the point where we can say, this is a curative surgery, the likelihood of recurrence is small, and the constructs are so extensive that the likelihood of fusion is not high, and these would be the cases that we can start thinking about using BMP. But at this point, I've not used it on any of my cases.
Has anybody in the audience used it in any setting in cancer, either a revision? Have you done it yet? Yeah.
I told the patient about it.
Yeah.
Did it work?
We'll see. See if those rods break.
I'm not seeing any hands go up, but I take it that that's, nobody's using it in cancer, even, and maybe just starting to. Hey.
For these cancer scare things, were there any, I saw your slide, but it looked like leukemias were the worst. Were there any other particular tumors that were thought to be more produced by this?
There were specific tumor types that were more that seemed to have a more statistical significance to the risk. And I'm sorry, I didn't study it in that detail to give you the answer to which ones.
Well, for some, it's just interesting because it gives you some idea of the mechanism here. Like leukemias, obviously that's a tumor that's probably more sensitive to this kind of thing. But in bone marrow transplants, you find different kinds of tumors more prevalent and so on based on neurological things. There's all kinds of factors that go in there. I just wondered if there was a pattern to this.
Yeah, I don't know that there's a discernible pattern that sort of makes pathophysiological sense, but there were tumor types that seemed to be more represented. Yeah.
Did anybody see a cancer evolution in a patient who did not have cancer in a place where they use BMP here? No. Rod, did you see any? No.
Thing.
Yeah.
There's a lot of talk, but there's no real evidence as far as I can tell.
Well, see, that could suggest that they had some underlying
Yeah.
predisposition
Yeah.
to develop cancer, in a general way or a specific way, and this year
Yeah.
pushed it farther.
Yeah. There are some case reports that show that if you have a surgery for the degenerative problem, like an ACDF, and then 10 years later you develop cancer, what you find sometimes is the cancer occur right at the site where you had the ACDF or the degenerative surgery. Some case reports, and I don't know if there's some breakdown in the protection area around there.
Someone once had a theory about these bone injuries. I don't know whether it ever worked out or not, but they were claiming that cancer was more common in people that had bone fractures because what had happened was stem cells had been released into the circulation, and these were progenitors of cancer. So, that would go along with that, although it could be some injury or
Yeah.
reaction or something.
Nick, what do you guys do in Vancouver? Have you used BMP on any of these cancer cases?
No, I not personally, and not into that. Like, I think it's a very good example. I have a hard time using it because even if we do curative surgery, we know that, the recurrence rate at 5 and 10 years, even with marginal or margin, are still like 20 to 30%. Like,
Yeah.
there's always of course, I would kind of have a hard time.
Yeah.
I totally understand why you would. Like, but I would potentially explore all the other options after I do that. If it's not possible, then I guess but I'm not personally.
Yeah. So what you say, you can never be convinced that you cured the patient. There's always a chance of a metastasis, and as such, there's no reason to use BMP on these patients.
I think you guys I've definitely seen like these, right? Like where you have like perfect, you're wide in the sacrum, you're very happy, and then they recur 5 years out, like in the muscle. So it's always hard to be totally, sure that it's cured, even if you're 5 years out.
Yeah. Anybody have any questions from the audience? Yeah.
Just to the point, is now in the rheumatological literature, there's a lot of, there's some data, saying that the use of monoclonal antibodies against something like prostate cancer, for example, tocilizumab for temporal arteritis was published to be contraindicated. And again, it's a signaling protein. So, by the same kind of mechanism, you wonder whether BMP has the same basis behind it, because it's a cellular mechanism. It's through signaling proteins that are activated, receptor cell activation, and there seems to be cross-reference from that. So I wonder whether it is okay in the setting where you can never be sure that there's no cancer, but you can be as close as you can be.
Yeah.